So let's move to the B part of it, which is onset of labor. It is characterized by true labor pain, the show, which is an expelled cervical mucous plug tinged with blood from ruptured small vessels as a result of separation of the membranes from the lower uterine segment. Labor usually starts several hours to few days after show. So the show is just a blood-stained mucus as a result of rupture of blood vessels when the membrane separates from the lower uterine segment. Third is dilatation of the cervix. A closed cervix is a reliable sign that labor has not begun. In multigravida, that's women who have given birth multiple times, the cervix may admit the tip of the finger before the onset of labor. So dilatation is just the opening of the cervix. So if the cervix is still closed, it's just a sign that labor has not begun. But you should note that in women who have given birth multiple times, the cervix is usually open as much as to contain a fingertip even before the onset of labor. So fourth is the formation of the bag of four waters, which bulges through the cervix and becomes tense during uterine contraction. So the bag of four waters is the part of the amniotic sac, that's the membranes, that lies in front of the presenting part of the baby, usually the head, during labor containing amniotic fluid. So let's move to the stages of labor. Labor is divided into four stages. First stage, it is the stage of cervical dilatation, that's the stage of opening of the cervix. Starts with the onset of true labor pain and ends with full dilatation of the cervix, that's 10 cm in diameter. It takes about 10 to 12 hours. Second stage of labor, it is the stage of expulsion of the fetus. Begins with full cervical dilatation and ends with the delivery of the fetus. Its duration is about 1 to 2 hours. Third stage, which is the stage of expulsion of the placenta and membranes. Begins after delivery of the fetus and ends with expulsion of the placenta and membranes. Its duration is about 10 to 30 minutes both in primary and multipara. So it's the same in both a woman who is about to give birth for the first time and a woman who has given birth multiple times. Fourth stage, it is the stage of early recovery. Begins immediately after expulsion of the placenta and membrane and lasts for 1 hour, during which careful observation for the patient, particularly for signs of postpartum hemorrhage, is essential. Routine uterine massage is usually done every 15 minutes during this period. So we'll begin with the first stage, causes of cervical dilatation. 1. Contraction and retraction of uterine musculature. So the contraction and retraction of uterine musculature will cause cervical dilatation. Second is mechanical pressure by the forebag of waters. If membrane is still intact or the presenting part, if they had ruptured, this in turn will release more prostaglandins which stimulate uterine contractions and cervical effacement. So mechanical pressure from the forebag of waters or pressure from the presenting part of the fetus will cause more release of prostaglandins which will stimulate uterine contractions. Third is softness of the cervix, which has occurred during pregnancy, facilitates dilatation and effacement of the cervix. So during pregnancy, the cervix softens over time and this facilitates the opening and thinning of the cervix. So let's move to the mechanism of cervical dilatation. In primary gravidas, the cervical canal dilates from above downwards. that is from the internal cervical opening downwards to the external cervical opening. In multigravidas, effacement and dilatation occur simultaneously. So in primary gravidas, the cervical canal opens from above, beginning from the internal cervical opening downwards to the external cervical opening, while in multigravidas, thinning as well as opening of the cervix occur at the same time. So let's move to the phases of cervical dilatation. We have A, which is the latent phase. This is the first 3 m of cervical dilatation, which is slow, takes about 8 hours, may be shorter in multipara. B is the active phase, which has 3 components: acceleration phase, maximum slope, and deceleration phase. So in the acceleration phase, the rate of dilatation of the cervix increases. In the maximum slope, which is the middle of the active phase of the first stage of labor, the rate of dilatation of the cervix reaches its highest point, while in the deceleration phase, the rate of dilatation of the cervix reduces as it nears dilatation of 10 cm. The normal rate of cervical dilatation in active phase is 1 to 2 cm per hour in primary gravida and 1 to 3 cm per hour in multipara. Note that if the rate is less than 1 cm per hour, it is considered slow or poor progress. This can lead to prolonged labor, resulting to various complications in pregnancy. So let's move to the second stage of labor. A is delivery of the head, and it begins with descent. So descent is a downward passage of the presenting part of the fetus, which is usually the head, into and through the maternal pelvis. So the descent is continuous throughout labor, particularly during the second stage, and caused by uterine contractions and retractions. The auxiliary forces, which is bearing down, brought by contraction of the diaphragm and abdominal muscle. So the contraction of the diaphragm and abdominal muscle also add as one of the forces resulting to the descent. Next is the unfolding of the fetus, that is, the strengthening of his body due to contraction of the circular muscles of the uterus. So when the circular muscles of the uterus contract, the fetus becomes straight in order to enable easy passage via the maternal pelvis. Next is engagement, which refers to the point during pregnancy or labor when the widest part of the fetal presenting part is usually the biparietal diameter of the head, when it enters the pelvic brim and is firmly fixed in the maternal pelvis. So the head normally engages in the oblique or transverse diameter of the inlet. Third is increased flexion, as the atlanto-occipital joint is nearer to the occiput than the sinciput. Increased flexion of the head occurs when it meets the pelvic floor according to the lever theory. So the lever theory explains how the fetal head flexes, that's bends forward, or extends, that's bends backward, as it moves through the birth canal, depending on where the force of uterine contraction is applied and where the head pivots. So increased flexion results in A, the suboccipital bregmatic diameter of 9.5 cm passes through the birth canal instead of the occipital frontal diameter, which is 10 cm. B, the part of the fetal head applied to the maternal passages is like a ball with equal longitudinal and transverse diameter as the suboccipital bregmatic, which is equals to biparietal, which is equals to 9.5 cm. The circumference of this ball is 30 cm. So, in a nutshell, as the fetal head meets resistance from the cervix, the pelvic walls, and the pelvic floor, the pressure acts mostly on the occiput, that's back of the head. According to the lever theory, this pressure causes the head to flex more. This reduces the size of the presenting diameter. It also changes the presenting part from the larger part of the head, which is the forehead, to the smallest part known as vertex, usually the posterior fontanelle, which leads. It also facilitates engagement and descent because the smallest diameter of the head now presents first and it can fit into the pelvic inlet more easily. It also improves progress of labor. Proper flexion means the head rotates and descends smoothly. Poor or incomplete flexion can lead to arrest, malposition like occipito-posterior or difficult labor. C. The occiput will meet the pelvic floor. 4 is internal rotation. The rule is that the part of the fetus that meets the pelvic floor first will rotate anteriorly so that its movement is in the direction of levator-ani muscles. That's the main muscles of the pelvic floor. That is downwards, forwards, and inwards. In normal labor, the occiput, which meets the pelvic floor first, rotates anteriorly 1 all over 8 circle. Fifth is extension. The suboccipital region lies under the symphysis, then by head extension, the vertex. Forehead and face comes out successively. The head is acted upon by two forces, the uterine contractions acting downwards and forwards, the pelvic floor resistance acting upwards and forwards. So the net result is forward direction, that is extension of the head. So sixth is restitution. Restitution is the alignment or turning back of the baby's head to its original position in relation to the shoulders after the head has been delivered. So after delivery, the head rotates 1 over 8 of a cycle in the opposite direction of internal rotation to undo the twist produced by it. Seventh is external rotation. The shoulders enter the pelvic in the opposite oblique diameter to that previously passed by the head. When the anterior shoulder meets the pelvic floor, it rotates anteriorly 1 all over 8 of a cycle. This movement is transmitted to the head, so it rotates 1 over 8 of a cycle in the same direction of restitution. So in a nutshell, external rotation talks about how after the baby's head comes out and turns slightly on one side, which is restitution, the shoulders inside the mother's pelvis also starts to turn to find the widest space in the pelvis. As the shoulders turn, the head also turns with them. The visible movement of the head is what is known as external rotation. B is delivery of the shoulder and body. Remember that A was the delivery of the head. So the anterior shoulder hinges below the symphysis pubis, and with continuous descent, the posterior shoulder is delivered first by lateral flexion of the spines, followed by anterior shoulder, then the body. So in a nutshell, the delivery of the shoulders begins with anterior shoulder, that's the one in front. This shoulder lies under the mother's pubic bone, that's the symphysis pubic. The doctor or midwife places one hand on each side of the baby's head and gently pulls the head downward and backward. This allows the anterior shoulder to slip out from under the pubic bone. So secondly is posterior shoulder, the one behind. Once the front shoulder is free, the baby's head is lifted gently upward towards the mother's abdomen. This brings the posterior shoulder down over the perineum and it slides out easily. So for the rest of the body, after both shoulders are out, the rest of the baby's body follows smoothly because it is much smaller in size. Gentle traction in the direction of the pelvis helps the baby slide out completely. No force is usually needed. The body often delivers spontaneously with the next contraction. So let's move to the third